also would like to extend a very special thank you to our sponsor, Bubbly Hall, and today lunch is provided by Mr. Hummus, which it looks and smells wonderful. Mr. Hummus will be at Bubbly Hall. Bubbly Hall, if you don't know, I'm sure you all do, is a new project underway on Central College Road. The food hall will open very soon with 15,000 square feet of retail, food, and event space. Bubbly Hall gathers flavors from around the globe, presenting them in a one-stop shop for an astounding culinary experience. Thank you, Bubbly Hall, for your support of Healthy New Albany and our community. We look forward to visiting. Today, we are taking time to talk about health inequities faced by sexual and gender minority people. The LGBTQ+ community belongs to almost every race, ethnicity, religion, age, and socioeconomic group. LGBT individuals face health disparities linked to stigma and discrimination. These disparities are exacerbated when people are unable to access care or are uncomfortable asking providers for the treatment they need. These disparities impact the LGBT community at all ages, with higher rates of suicide, substance abuse, and mental health disorders. Stigma, discrimination, and other related factors put LGBT individuals at increased risk for negative health and life outcomes. We know that awareness and gender-affirming, culturally competent healthcare can make a difference. Here today to discuss these important topics, we have with us Amanda Erickson, Director of Education and Outreach from Kaleidoscope Youth Center. Kaleidoscope focuses on advocating for LGBTQIA+ youth across Ohio through education for youth-serving professionals, including teachers, social workers, and more. Dr. Matthew Adkins is a family medicine specialist in Columbus, Ohio. He currently practices at Grant Family Medical Medicine and specializes in LGBTQ medicine, HIV pre-exposure care, sexual health, and gender-affirming care. Thank you both so much for being here. We have so much to talk about, so I'm going to jump right in, and I would love for each of you, if you could please, to just begin sharing a little bit about the work that you do every day in your field and your current role.
Well, yeah, thanks so much for having us today. Again, my name is Amanda Erickson. My pronouns are she, her, and hers, and I'm the Director of Education and Outreach at Kaleidoscope Youth Center. So Kaleidoscope Youth Center, if you haven't heard about us, is the largest and longest serving organization in Ohio dedicated to serving and supporting LGBTQ youth. So we do that primarily through our drop-in center, which is an after-school program that's open to ages 12 to 20. So kids can start coming on their 12th birthday, they age out on their 21st birthday. And we have all kinds of just social events for them in a safe and affirming space where no one is going to judge them for who they are. Some of that is, discussion groups specifically about gender and sexuality. Some of it is art club and movie and pizza night and things that are not at all, heavy topics or related to an LGBTQ identity, but just provide that space for them. Through our education and outreach program, we're trying to take that safe space that we've cultivated within the drop-in center and extend it into the rest of the community through community education, training, professional development, for pretty much anybody else who works with young people, making sure that they have, a general idea of how the upcoming generation looks at gender and sexuality, because for each generation, it's a little bit different. And so kind of have to keep up with that, keep up with language evolution, things like that. And also just best practices for working with LGBTQ kids. So whether that's professional development for teachers or librarians or social workers, anyone who's coming in contact with our youth, we want them to have a basic understanding of where these youth are coming from and how to best support them.
Thank you.
Yeah.
Dr. Ack.
Again, my name is Matthew Atkins. I use he, him pronouns. I am a family physician at Grant Family Medicine downtown. This is where I did my residency training, graduated in 2017, and then have stayed there since then. The majority of my clinical work and teaching with the residency largely revolves around LGBTQ+ health issues, sexual health issues in general, and the focus of the safe space within the healthcare setting. Making sure that patients are able to bring their full and authentic selves to the doctor so we can actually meet their needs and meet them where they are.
Thank you for the work that you both do. Health disparities, as we discussed, among gender minorities and the LGBT individuals, we all know are at a higher risk for certain negative health outcomes, higher rates of suicide, substance abuse, and so forth. Can you talk about these statistics and really just what you're seeing in those that you're working with?
I think when we're looking at stats, I don't have any of the numbers memorized myself, but we consistently, with every survey or research study that is done, see that LGBTQ plus individuals in general have higher rates of risk for mental health issues and suicide rates. And that exponentially gets larger for folks who have gender expansive experiences, so transgender, non-binary folks. So I think that's just, it's been shown time and time again. So I think it's certainly worth us focusing on. That's why having discussion in spaces like this to explore why that is important.
And I will say, I do have one statistic. According to CDC, 48% of sexual minority students have seriously considered suicide. Another study, which I have to say, the statistics were shocking. When I started digging in, I almost couldn't believe. Another study published by the National Institute of Health showed that youth who are lesbian, gay, or bisexual are 5 times more likely to attempt suicide. So I think, as you said, the statistics are obvious. It just as it relates, and I know when we spoke previously, you mentioned use of substances, lower GPAs, unplanned pregnancies. Can you talk a little bit about that and how that is affecting the kids that are struggling?
Yeah. So we have data that shows us that in general, schools are not really safe for LGBTQ students. And we know that, like, as humans, if we are entering a new situation that we really feel is unsafe, we're going to try to avoid that situation and remove ourselves from it. So students who experience some kind of discrimination at school related to an LGBTQ identity are more than, I think, 3 times more likely to have missed school in the past month than the same students who did not experience that discrimination. So when you're not going to school, it's hard to do well in school. They have lower GPAs on average by about 0.3. And I think it's interesting to note that none of that is like gay youth versus straight youth or, LGBTQ youth versus non. It's thinking about who is experiencing that prejudice and discrimination. So, the risk factors that we talk about aren't necessarily, tacked onto somebody as soon as they come out with a certain identity, but it's really about how everyone around them is responding to that and whether they find, spaces of support and belonging, or whether they're being treated negatively and have to figure out, poor coping skills or just removing themselves by not going to school.
I spoke previously, sadly, she wasn't able to make it, but Precious Singo, a representative from Pride New Albany, was somebody that I interviewed, and she talked a lot about safe spaces, and she says a lot of people feel like this community is a safe space, and she's not necessarily sure that it is. Can you talk a little bit about what those safe spaces are and how we can create them as a community?
Yeah, it's a challenging thing because is this positioned correctly? Can you hear me? I see some faces sometimes like you can't hear me.
No.
Yeah.
It's not as loud as mine.
Yeah, let's do it this way.
Is this any better?
It is.
Yeah, okay, great.
Perfect.
So when we're thinking about safe spaces, I think the important thing is always to be coming from the perspective of the folks that who are the subject of that concept. It's really, it's a little challenging for us to presume that we've made a safe space for someone else if we're not actually checking in with them. So I think there's a whole lot that goes into it. And just even starting from the fact that people who are part of the LGBTQ plus community, if you're not part of that, it is really difficult to fully understand the pervasive and everyday things that feel unsafe, that feel like, I don't know if the people here would appreciate me or accept me if they know XYZ details about who I am. So I think it's a lot of times easy to fall into that, like, oh, we accept everybody type of mentality, which I think we all strive for, of course, but I think it's really easy to miss the details, especially if we're not checking in with the actual people that we are claiming to have a safe space for.
Mm-hmm. And asking them, what is
Yeah,
a safe space
yeah,
to mean to
yeah,
you
yeah.
and how do we create that
Right.
affirmatively?
Yeah,
And anything else you would add?
No, I think just being visible, I think is really important because we also often think that we've created a safe space. Nobody tells us that it's not safe, but also like we're not actively showing that we're making that effort to the people that it matters to. And I think young people in particular have so many negative experiences that they have to go into every situation expecting it to be a negative situation. And so if we're not actively, yes, I'm here to support you, yes, I love you, yes, I want this to be a safe space, if it's just kind of neutrally quiet, the trust isn't necessarily there. So even if we think we're doing everything right, you know, we're not building those systems of trust.
So it's not enough to just be neutral. You
Right.
almost have to be affirming
Absolutely.
in a proactive way,
Yeah.
which makes perfect sense. I did read a little bit about microaggressions and that stigma-related stress towards LGBTQ kids and peer victimization. And that's one thing that is hugely impactful on youth, particularly as it was published in a pediatrics journal that peer victimization is one of the leading cause, interestingly, of high-risk sexual behaviors in middle and high school students. So LGBT youth are frequently bullied at schools. They get into fights, they engage in truancy, they struggle with emotional distress and problems. Early victimization and emotional distress explained about 50% of disparities between LGBT and heterosexual youth. So it's that emotional distress. And can you talk a little bit about the peers and how your peers impact you?
Yeah. I think it's easy for when we think about like trauma, right? And how trauma is affecting us. I think we tend to think about really large scale trauma, or we think about really impressive events that happen to someone. We think of hate crimes, things like that. And we forget about these microaggressions, these little tiny things that often are unintentional, right? Microaggressions can be intentional or unintentional. They can be so subtle that nobody actually knew what happened. Like they're the things that leave you sitting there feeling like, I think I just got insulted. Like that made me feel icky, but I can't quite put my finger on why or how or what it is that felt so weird, right? And so when all of those are happening day in and day out repeatedly, they really build up and cause the same kind of trauma that, you know, one single large event would have on someone's body and mind. So I think that's important to think about. You know, we hear from young people about what other students are saying in the hallway at school. And sometimes we ask, you know, oh, where were the teachers, right? And first, teachers are exhausted. And they're in their classrooms getting ready for the next class. And like kids are good at knowing who's around to be able to say what they want to say. And all of that is still happening all the time as well. I think one of the things we hear the most often is that kids are still saying things like, that's so gay, all the time. And that surprised me when I started doing this work. I was like, I thought we left that, you know, when I was in 6th grade in 1999. We did not. Like, it's still out here being said all the time. And those little things where, you know, other students don't even realize that what they're saying is wrong. Maybe they haven't been intentionally taught that that's not a thing that you say. And so they're hearing those things all the time.
That the term that you're describing as far as the chronic PTSD,
Yeah.
like the buildup of that complex PTSD, is something is often that's talked about in the literature as far as something that's been small things but persistently. And I can share personally from my childhood as growing up in a small religiously conservative community that I knew that there was something different about me. By 10, I didn't know what that really was because I was 10, but I also simultaneously knew that the environment that I was in was not a safe space for anyone to know that. And I was 10. So I lived with that through adolescence, and that like daily repeated trauma, essentially, of like me feeling like I was not in a safe space, definitely like that adds up. And like my story is not unique, and many people have stories that are worse. And I think that's the second point I wanted to share is that we're talking a lot about disparities and things like microaggressions. But I think something to always keep in mind is that we're talking about LGBTQ plus issues right now, but like if you're in any other category, of a marginalized group or have the potential to be discriminated against with some other part of your identity, whether it's race, ethnicity, religion, gender, that compounds things exponentially also.
Absolutely. It's like a triple whammy in many
Yeah.
cases.
Yeah.
I found it devastating to read that LGBT youth represent 40% of all young people experiencing homelessness. So it really, I mean, it tells you something. And then it kind of led me to reading a little bit about the power of family acceptance versus the impact of family rejection. I don't know if you could just speak to that, and I think you did personally.
Yeah.
But just what can families, and it's a difficult situation for some people, I'm sure. How do families manage it? How do you have those discussions? Where do you begin?
This is a tough one for me to talk about, I think, but I mean, I think in general, when you're trying to support your kids, everyone wants it to be a safe space. So I think a lot of times there's just, in a lot of places, and especially like, you know, in times past, but still now, people are just not as aware that there really can be the differences. So I think just making sure that kids know that no matter what questions or concerns or things that they think they identify with, that they have an okay place to talk about it. I know that feels like a little bit of an oversimplification, but I mean, really the power in just the kids knowing that they really can talk to you about anything without there being a lot of judgment or like skepticism or questions or minimization. Yeah. I have other thoughts. I don't know that I can really get.
No, you're fine. Everything he said, absolutely. I think kids really need to hear from family members that they are loved, that they do belong, that regardless of their identity, regardless of the name they'd like to use, regardless of how they'd like to dress or what clothes they want to buy, like they deserve to have a safe space to land. And again, if we're not being really visible and outward with that support, our kids may not necessarily believe it because they have friends that are experiencing the opposite. They're seeing the opposite things happen. And so they're nervous. They're worried that, you know, oh, my family's going to react the same way. So it almost like you almost have to become that over the top parent that the kids are like, mom, like, stop. I know. Okay, fine. Like you want that to happen because the alternative is that they don't know if this is really a safe space.
That's something Precious Singo from New Albany Pride talked a lot about, and said that she just wanted me to kind of emphasize the fact that they're there and as an organization for families in need. So she said, literally, if somebody comes up after and wants my phone number, please give it to them, because having those family connections and having one another to find resources and to kind of walk the road together, she said, was so impactful for their family. And she is that cheerleader. And that was really her message, was that that representation is so important for that child or family member, whoever it might be. So if I had to say anything, I think that was her resounding message, is that Pride is there, New Albany Pride, to help connect people to those resources and really walk together as family. So just for Precious, please, if you need contacts or help with that, New Albany Pride is a great resource for that. And she personally is very dedicated to being that representation in the community to find those safe spaces. So Dr. Atkins, we talked a lot about, well, we've talked here LGBTQIA+ and words and pronouns. And so can you sort out the alphabet and what we're supposed to use and how we're supposed to use it and all of those things?
So language is tricky, and language evolves. We all, I mean, you mentioned several different versions of something that starts with LGBT, and then how many letters are we adding? And sometimes it almost becomes like a little bit of a comical thing when we're trying to figure out what to say. And I actually trip over the words or letters a lot of times. But there is seriousness behind that as far as like the idea of inclusion. So, you know, I think there is not a great strong answer. I've been in many different leadership groups where we're trying to have this discussion about what term to use actually. I think my current thing, at least for the past year or so, has been that I like to use the LGBTQ+, and I stop there because I feel like the plus encompasses the rest of the things and it's not meant to be exclusionary. It's just recognizing that we have limits with like the letters that can come out of my mouth without me tripping over them, and I already do it with just like 5. So as far as what is right to use, I think approaching the topic of language and the correct terminology and trying to be socially sensitive or politically correct or whatever language is used around this, I think is mostly what I would say is just be flexible. Like, if people are upset or offended by something, it's not because they want to be, really, it's just because they've had life experiences that have led them to have things feel sensitive and be triggered by certain things and being excluded. So I think being flexible is the biggest thing, and just being okay with the concept that, like, we know this about so many other things. We use lots of words now that were not used 20 years ago. There's lots of words used 20 years ago that we would gasp if we said it now. So, I think just being kind to ourselves and that, not being rigid, we have to be flexible. And then, if you do find yourself in a situation where you maybe said something that wasn't the best, or someone's upset about something, correcting it, acknowledging that, and moving on quickly is usually the best thing. It doesn't do anybody any good to profusely apologize and belabor a point like, oh my gosh, I'm so sorry, didn't mean to offend you. Should probably just fix it, move on, because otherwise we're kind of lingering on that topic, and I think it potentially just makes it worse. I don't know if that got to the question you had. Was there?
No, I think
Okay.
so. Yeah, absolutely. No, and you, when we spoke previously, you really made such a beautiful point of it, because we all struggle with it. And I even was too, in preparation for this. Like, I want to get it right. I want to say it right. And I think that the overarching message that you delivered to me that was really helpful was, like you said, people aren't trying to be particular because they want to be difficult. They feel like they have not been seen, and they want to be seen. And so that's what's happening there. And it just made me see it in such a different and beautiful way. Like, okay, I want to use the right words because I want to affirm that I see that person, and it changed the whole perspective for me. So it was really helpful. And like you said as well, previously, don't make assumptions necessarily based on the way someone may present themselves. It's okay to ask, right? I mean, could you talk a little bit about that?
Yeah. I know you had mentioned you had some discussion about pronouns, so you can jump in at any point.
Sure.
Do you want to start?
Okay, sure.
Yeah.
So when we talk about, and somebody had asked, are you going to talk about pronouns today? So maybe we can take that as the tangent for this. And yes, let's talk about pronouns now. We all have pronouns. Pronouns are the words that we use for ourselves when we don't use our name, right? So you can all think of your name and also the pronouns that you would want somebody to use if they were referring to you. So those are most often going to be she, her, and hers, or he, him, and his, and then sometimes also they, them, and theirs, which can be used as a singular pronoun when we don't know what pronouns somebody uses, or when someone has a non-binary identity and they, them feels better to them than she, her, or he, him. Right. There are other pronouns too. For the sake of today, we'll stick with the big 3. But there are lots of young people that are exploring other pronouns as well right now. But all it takes to find out what someone's pronouns are is to ask them in the same way that we ask their name, right? So if someone's going to walk into the room and I say, oh, hey, George, how's it going? And they're like, well, my name's not George. And I'm like, cool, well, you look like a George to me, so I'm going to go ahead and call you George. Like, that's not something that we do. We ask them what their name is, and then we use that name accordingly. So when we ask someone what their name is, we can also ask what pronouns they use. And that way we know, right? That way that person has the opportunity to actually tell us, these are the words that I want you to use for me, so that we don't have to get it wrong. We don't have to make somebody feel, less than because we've made an assumption that was wrong. We don't have to feel awkward and trip over ourselves apologizing. We ask ahead of time. If asking feels a little bit weird, which it does in certain situations, like it's much easier to ask when you're talking one-on-one with someone than with a group. But you can set that stage by introducing yourself with your own pronouns. And that kind of clues people in to know, like, hey, this person knows what pronouns are. So maybe if I told them that my pronouns were they, them, or something that they wouldn't have assumed, they'll actually try to use the correct pronouns versus someone who doesn't introduce themselves with their pronouns. They're kind of thinking like, okay, I'm going to continue to tread with caution. And then at some point, maybe I'll share my pronouns with someone. So that would just be like, hey, my name is blank and my pronouns are blank. It's as easy as that. And then if someone looks at you like you've thrown a second head, they don't know what you're talking about, then you have that teaching opportunity like, oh, well, I learned about pronouns. This is what they are. Should I call you he or she? And at that point, they've usually caught on.
I think it's important to recognize too that it's okay that this feels awkward or like different because we aren't socialized. The reason that this is new is because we've lived in a society and still do where we make a ton of assumptions, myself included. Like I talk about this stuff all the time and I still regularly make assumptions about people's pronouns, regular basis. So I think just giving ourselves grace with that and recognizing that, you know, we've lived our entire lives not thinking about using our pronouns with introductions. So that's okay that it feels different. But also give it a perspective of like, I think I have heard sometimes when people are frustrated, it's like, oh, it's just too hard and they get really frustrated. But we do lots of difficult things, you know, like thinking about pronouns and like bending ourselves to think about, I shouldn't make assumptions about someone's gender identity. Like we've probably all done way more challenging things. So, you know, give ourselves a grace that it feels different and is a challenge, but, you know, don't let the challenge seem like it's bigger than it is. Like I regularly have to do it myself. And I'd say that one of the things that I'm trying to do personally that I feel like is helping me, and everyone's different, is that I'm trying when I am meeting someone to make myself use they, them pronouns as a neutral starting place. Because maybe some people use that all the time if someone's non-binary potentially, but also when you use they, them pronouns in a singular sense, like, oh, someone left their jacket here. Like we do that anyway, a lot of times when we have no idea about the person. So I'm trying personally to make myself use that when I'm starting as a starting place. And sometimes I remember it, sometimes I don't, but that's what practice is about. But that's just a tip that someone mentioned to me that I feel like is helping me a little bit work on me not making assumptions every time that I end up meeting someone based on presentation.
Thank you. Well, kind of along those lines, speaking of the work you do, it's fascinating. And I feel like you're very cutting edge kind of with the gender affirming care that you're working with. Could you share a little bit more specifically about what you do every day in the clinic?
Yeah. So gender affirming care in general is just at its basic parts is providing a safe space for people to bring their full authentic selves and bring up their concerns and things that may or may not be of interest for them in pursuing treatment. A lot of times I feel like we start from a place that gender affirming care or transgender medicine sounds really scary and like real fringe and oh my gosh, what are you really doing type of thing. But I really think at its basis is me trying to put aside my assumptions and boxes and checklists that doctors don't like a lot of gray. I don't know if you all know that, but like we like black and white answers. We like to find answers, you know, and move on. So setting in that gray is the biggest challenge, honestly, of letting someone bring themselves to us. And then figuring out what their goals are, because for everyone that is different. So for some people, gender affirming care is literally just a space where they can talk about their gender identity and not have to hide it from their doctor. That's it. Like sometimes that's where it starts. Sometimes it's non-medical, non-surgical things. Like it can be a speech therapist working with someone to do some voice modulation. It can be things like changes with how one presents themselves or clothing options. So, but then when we think about the actual medical treatments or surgical treatments, there are a variety of surgical options that various people will choose to do. But from what we do in our office, the great majority of it is hormone treatment. And the process for that is making sure that someone has a clear sense of their identity, that it's not been something that has been a more recent thing. So this has been a long-standing challenge for the person that has caused significant distress in their life. So usually all that takes is the person just telling us their story, and I need to believe them. And then after that, if hormones are something that they want to be doing, we figure out what to do for them for that. There's lots of nitty-gritty details, but I mean, I would boil it down to is that in a lot of ways, it's not that complicated, and it is way simpler than a diabetic patient or a high blood pressure patient who I can't get controlled. Like the medicine parts of doing the gender affirming care and prescribing hormones for someone is not overly complicated or dangerous. There are way more complications for other health conditions and treatments that I have. So what more details?
Well, I just, maybe specifically, just not even specifically, just in general, you're one of very few, it sounds like they're not teaching this in the medical schools, right? It seems like we need more competencies in medical school to kind of elevate this, but you are doing this every day. You're even teaching residents. So how does this begin to infiltrate traditional, primary cares and so forth?
Right. So when I was in medical school, I think I might have been one of the first classes where some of the professors at Ohio University, Jane Balbo and Katie Krupp, started doing some lectures at all about LGBT care, because they advocated to have some time allotted for that, because previously there was nothing. And I mean, I was in medical school starting in 2010, so it's not like it was 20 years ago even. This has been relatively recently, so it is not allotted a lot of time in curriculum, and that goes the same for medical school as well as residency training. And when I learned it, I honestly ended up learning it on the fly. I put myself on a list of LGBT friendly providers, and I had a patient come from Southern Ohio, drive an hour in, and wanted gender affirming care. And I had no idea what I was doing. I was a second-year resident. The attendings I worked with also didn't have any idea, but we decided it was a need and we needed to figure it out. And so that's where it started. And kind of have just done like the self-learning since then. And like I had mentioned, it's not overly complicated. The most challenging parts are the social skills of learning how to not be trying to put people in boxes and make a lot of assumptions. So I think that's why it's important that we're doing it at Grant, and I'm grateful to be at a place that's letting us do that and is prioritizing that. And there's a number of residents who have interest in doing that. Our goal is that, for these residents when they're graduating, especially for the ones that have interest in it, they'll be able to do this. And so this past year, we had a couple residents who had kind of done a specialty track with me as far as doing LGBT care, and they are ready to be able to do this gender affirming care at their outpatient practices that they're going to be at now. So I think it's just a slow process because it's not built in. I mean, LGBT issues in general, but especially gender affirming care. So I think that's why we need places to be allowing the residents to be learning this during training, because once we get out, unless you're like me, who gets to stay at a residency program and be constantly challenged and made sure I'm up to date because I have to be with the residents, I wouldn't be learning lots of new things if I was just out in regular outpatient practice. So having more programs do this, because it can't just be a grant and a couple residents a year. That's great. Like, that's amazing. We have 2 new family physicians who are out in the Columbus community now who can do gender affirming care. We don't have huge patient panels right now. So there's a lot of access even with those 2, but that's not enough. That doesn't stop there. So I think just we can get other programs doing this and increasing the time in curriculum, both in med school and residency, that would go a long way.
Seems like it's heading in that direction, but as of all things, of course, it takes time to move the ship. And you said something really cool, I thought, when we talked earlier. Gender affirming care isn't scary, right? I mean, it doesn't have to be scary. It's just evolution, right? You talked a little bit about heteronormativity. Can you talk about that?
That term is just a term that encompasses the predominant social concepts of like people are assumed to be straight or heterosexual. So the assumption, default, the normal is that. So I think that's the concept. That's what that term means. And when that's being used, that's in general talking about the challenges it presents for folks who do not identify as heterosexual, because the entire world around us is defaulted to that. So you, regardless of, even if you feel like maybe people aren't even being disparaging, it could still not necessarily feel safe. Like if I'm the only gay man in the group, I could still feel a little out of place potentially, if everyone else around me is not identifying that way. So it's usually used in that.
Well, it's a lens almost, right? And you're making yourself aware of this lens that you automatically live
Yes.
in the world with.
And I have that too. Like as a gay man, I have been socialized to think that that is the normal, even though I talk about it, but like I also do. So it's a constant thing for us to try to be thinking about, be aware of.
When we spoke, you talked, and I asked for maybe the top 2 or 3 things that you really wanted to make sure we discussed today. And one of those was pre-exposure prophylaxis and the prevention of HIV. Can you
Yeah.
talk about that?
So pre-exposure prophylaxis, or PrEP for short, is a daily medication that you can take to prevent HIV transmission. It has been FDA approved since 2012. So we're at a decade now. But the great majority of people in general society do not know what we're talking about. There are even a large number of folks within the LGBT community that don't know what it is yet. And then when we think about medical providers, I haven't seen the most recent stats about people who are aware. So I hope that the awareness has at least gone up, but there's still a lot of providers who don't know anything about it. But there's even a larger number of people who don't feel comfortable. So it's another thing that ends up feeling like it's scary, and it's just an unfamiliar thing, and it's not built into curriculums as part of your default learning that everyone does. So it feels like it's something new and different, but it's really not. So there's not a lot of access points. I have had referrals from various primary care providers where a person's wanting to get on PrEP and their family doc, primary care provider doesn't do it, like sends them to someone else as opposed to just figuring it out. So it's a very effective tool for HIV transmission or prevention of that. If used daily, it can prevent transmission up to 99%. So like people who are at risk at all should be on this medication. It is safe. There is not a risk of complications from taking this medication daily. And is just extremely effective. Another thing is that there used to be cost barriers because when both of the options were brand name medications, they were expensive and the insurance companies sometimes didn't want to pay, and you had to use copay coupons, etc. Thankfully, it has got the United States Preventive Task Force, something, who makes our prevention guidelines for things like when you should get your mammograms or colon cancer screenings. They also made the recommendation that PrEP be used for HIV transmission prevention, and it got like top grade A level recommendation. So because of that, and the way that the Affordable Care Act is set up, that has to be covered by any insurer at zero cost to the patient. Just like your mammogram should be $0 through your insurance, getting PrEP should also be $0. So as long as someone has insurance, and there's still plenty of people who do not, unfortunately, but if someone has insurance, it should be $0 to get the medication. It should be $0 to get your testing done for it, as well as your office visit. If your office visit is only for getting the HIV prevention medicine, that should also be covered. So access has greatly increased for people who have insurance, but it's still just something that not enough people know about. And in fact, the CDC made updated recommendations for who we should recommend this for in December of last year, which included us making sure that every time we talk about any sexual health concerns at all with a patient, if they are sexually active, they should know that there is a pill that can prevent HIV transmission. So it doesn't matter what the person identifies of, age, number of partners, it doesn't matter. That everyone needs to be counseled that this is available. Not that we need to recommend it to everyone, but like we need to be, that needs to be like, hey, you know this is available? Okay, cool. Even if the answer is like, no, I don't think that's for me. So we just need to be talking about it more, and we need to get more primary care offices feeling comfortable prescribing it, because it really just takes some regular routine STI testing, blood work, and then taking a pill daily. So we need to increase access for that, especially for marginalized populations and people who are at higher risk.
Why do you think there is such a lack of awareness? Is it a stigma issue? What?
I think so. Yeah. I mean, it's not in our standardized curriculums. And then also in general, sexual health things just don't get talked about the way they should. I mean, pretty much everyone has sex at some point. I mean, I think we can all agree that like there's maybe some people who choose not to, but the great majority of us at some point have had sexual contact with someone. But yet we, in society in general, we talk like it's some kind of like taboo thing or something that you shouldn't feel comfortable talking about, or that you should only talk about with your partner and that's it. Or so there's just a hesitation to talk about it. And that definitely is part of medicine. Medicine in general is a conservative old institution. So it's still, we do not great jobs talking about sexual health issues. So yeah, I think there's stigma attached to HIV for certain still. So bringing this up, there's concerns of like, oh, I'm sure some providers are like just uncomfortable with the questions to bring up to see if someone would be interested or if they should be on it. And there's worries of like, oh, I wonder if this patient's going to think that I'm suggesting they're doing X, Y, Z, and that they might be offended. We just do terrible jobs having open conversations about this. One thing that I try to do, and I still feel like is not necessarily in suggested guidance anywhere, so this is maybe a little fringe in some ways, but I have a little bit of selection bias because most of my patients are LGBT folks. So sometimes I kind of make assumptions also, but in general, a lot of times your doctors don't necessarily need to know all the details of your sex life in order to make sure that we're doing proper screening for you. Like I just need to make sure you're aware of all of the STI testing you should get done, which is not just like an HIV blood test and a urine sample. There are more things than that. And I just need to know that we're doing full screening. I don't need to know the details of anything that's not really relevant to make sure that you do all the proper screening. So I think sometimes we make it more complicated than it needs to be, because then there's all this fear about asking someone about the number of partners and like the anxiety that comes with that, or the sexual practices and the types of sex and the body parts of the partners that they interact with. Like all those details, like maybe that we need to talk about it, and that's fine. It should be a safe space, but a lot of times I don't need to know, and I don't want to know necessarily. It doesn't really help our decision to what we're going to do. So yeah, I think there's a lot of stigma in general. We need to destigmatize talking about sex and it just being a normal thing that like every human, for the most part, has had some interaction.
Well, your other priority, which I think was extremely important, is normalizing proper STI testing, and removing the stigma and just using the broad spectrum testing instead of pieces and parts. Can you talk about that particularly?
So a lot of folks are unaware that people can have gonorrhea or chlamydia infections in their throat or in their rectum, and so we often are missing infections a lot of times. So full sexually transmitted infection screening should include blood work for HIV testing, syphilis, which is a bacterial STI, but we test that from the blood. But gonorrhea chlamydia testing is done at the specific body sites. Because if I do a urine sample, that doesn't really tell me anything about the bacteria that could be in my throat or my rectum. So a lot of times the default is just a urine sample, and they think, oh, my gonorrhea chlamydia testing was positive or negative, and you kind of move on from there. But it is very possible for people to have gonorrhea or chlamydia infections in the throat or the rectum, and a lot of times there's concern about asking the history. So typically what I end up doing is I just say that spiel of like, there's HIV, syphilis testing from blood, There's a throat swab that I will do for you for gonorrhea, chlamydia. There's a urine testing that you can do in the bathroom, and there's a rectal swab that you will do in the bathroom on your own. We teach you how to gather the swab, and people generally like unclench a little bit when they hear that they can do the rectal swab in the bathroom on their own. And that would cover all of our testing that we need. You should only tell me to cancel one of those tests if one of those body parts that you mentioned has had no contact with someone else's body parts. I don't care which body part, body fluids, don't care which fluid, or any sexual toys that are used. So if that certain area has had zero possible contact with any of those things, then we can cancel that test. So sometimes people are like, yeah, I don't need the urine sample, or I don't need the rectal swab. Okay, but I generally start with that full list and then force someone to tell me that we're gonna cancel one of those tests, just so I don't put them in the situation where they're like, yes, please give me the rectal swab, because that might be uncomfortable for someone to say based on how comfortable they feel talking about their sexual practices. So that is what full testing is. And an example that I give often is that I had a real life situation where someone had a trichomonas urinary infection, a throat gonorrhea infection, and a rectal chlamydia infection. And this was all at the same time, and none of those were in the same sites. So if we hadn't done the full testing that I just described, we would have only caught one of them, only given the proper antibiotics for one of them, and then left this person to continue to have the other two infections, which can cause complications for people if they're not properly treated, or potentially also like give it to someone else also because they were unaware, because they thought they went to the doctor and got checked out for everything and properly treated, but they weren't. So that's full STI testing.
Well, and statistically, you said 50% of people have STIs.
Yes.
So let's talk about destigmatizing.
Yeah, I mean, some form or another of a sexually transmitted infection, half of the people in the US who've been active at some point have had something. So whether that is like any of the list of things we just talked about, or like herpes, so that number seems a little shocking, but that, I mean, it's truly someone has encountered this in one way or another. And a lot of times we use such stigmatized language around sexually transmitted infections, like talking about if someone's dirty or clean, and using those loaded words. But it's really like you guaranteed have family members, friends, maybe former or current partners, or you yourself have had one. So it's just something that we need to just talk about. This is what we should do for full screening. A lot of times we doctors order lots of things that are probably not necessary. Like for the 30-year-old who is otherwise healthy, I don't need to order a lipid panel for a cholesterol or a diabetic screen unless there's some other risk factor, like they are otherwise healthy. I don't need to order that stuff for them. But it's probably way more relevant that we get full STI testing if there's someone who's sexually active. So yeah, we just need to normalize that that's what full STI testing is. Yeah.
Thank you. Well, switching gears a little from the medical side, that was a ton of fun.
Yeah.
Just to the commute, we love having a physician here to walk us through all that. It's important information. You just have to talk about it, right? Knowledge is power. So just from the community-based perspective, and the same kind of question to you, Amanda, as far as priorities for you, you engage with these kids and these youth every day in different ways, education and engagement. What are the things that are most important to you that you see? Or the programs that you're working on that are most important?
I think the most important thing to think about when we're talking about LGBTQ youth is just believe them and trust them and listen to them, period. And I think with that starting point, we can work on so many other problems that come down the road, whether it's an issue with a parent at home or a teacher at school or accessing gender affirming care. Like if we can just talk to the young person and actually listen to what they're saying to us and say, you know, I'm here to support you however you need, let's do this, then we could get so far. And I think our society is often more likely to put a different adult as the authority in the situation and say, no, you know what, I'm the adult, I know what's best for you in this situation, here's what we're gonna do, rather than listening to the young person. The adult may say things like, you know, are you sure that that's how you're feeling? Or, you know, do you really want to do that or wear that or say that? Or you're just going to change your mind next week, or you're going to grow out of it, or you're going to meet somebody later, or all of these things that really just kind of cut you down to not being trusted. And if we could trust them, if we could believe them, and then if we could go along with whatever support they need, I think that solves some of the biggest issues that we're seeing.
That's really interesting. I can't think of his name. We had another physician not too long ago talking about mental health, and that was really his message too.
Yeah.
Listen and believe them. If you can make that authentic connection, the whole world opens up,
Absolutely.
right? Without judgment, without all of those things. It's so simple, but yet, and I think Dr. Atkins, you said something similar, you know, giving them the opportunity and the freedom to be honest. And you kind of said, you know, people are afraid to talk about it because they think, oh, we're going to influence that, right? By talking about it, we're going to suggest this to them. What do you think about that?
Ooh, I'm not sure if I understand where we're coming from with that.
Well, you had kind of said that it's not, we can talk about it and we can engage about it, and you're not going to, if somebody is that way, if they're LGBT, they're already that way.
Right.
You're not going to create it in their mind.
Right.
I think that's legitimately sometimes parents' fears or.
I mean, not doing what you just described and believing them and creating that environment does nothing to change that reality. It does not change that at all. So ignoring it or not creating a space where the youth can talk about that, or adults, I mean across the board age spectrum, but that doesn't change the reality of any of these issues. You know, these LGBTQ plus identities are not easy. So it's not like if someone's experiencing or thinking about any of this and identifies as one of those, it's not because this was a fun idea or trendy. Like, a lot of times you see and you hear things that it's like, you know, popular now. It is not. It is definitely not. It may be more accepted and more supported than it used to be in general. There may be more visibility, but it is still not an easy thing at all. So if there was some way around it or a choice involved, I don't think any of us would choose that because it's just hard. It's hard. So yeah, I think that's a huge point of what you were sharing, is that you just really have to start from like listening and believing them, because us talking about the issues openly does not in any way change who that person is. And it, in fact, just creates more room for things to fester and build up and all sorts of other unfortunate complications that can happen if someone's not given that space to be themselves.
Well, and I have to say I was shocked to start, as I was digging into some of the literature and reading, I came across something called conversion therapy. And I couldn't believe it, to be super honest. But some of the statistics were 2 out of 3 LGBTQ youth reported that someone tried to convince them to change their sexual orientation or gender identity. Conversion efforts are directly related to suicide attempts. It's really like a direct 1-for-1. It was shocking, the statistics. It was akin to torture. It was in a pediatrics journal. And any attempt to change a youth gender identity or sexual orientation can have lasting or harmful effects. Have you seen any of this?
Yeah, so interestingly, and if we could take a minute for a call to action too, conversion therapy is still legal in Ohio. It is not, ethical. Social work ethics say that you don't do conversion therapy, but according to our state laws, that can still happen. And so conversion therapy is happening a lot of times, like in faith communities, at churches, for example, where, it's not a licensed social worker that's engaging in this practice because they'd be going against their ethics, they could lose their license, right? But it's someone else in the community is providing this, counseling, as they would call it. It's not therapy, like it's a misnomer. It's incredibly harmful, but it's absolutely legal. And our House of Representatives in Ohio does have a bill currently that would ban conversion therapy, which many other states have already done. So if you wanted to leave here today and call your state representative and let them know that it would be a good idea to pass this ban by the end of the session, that would be fantastic.
It's my bill.
Yay! Thank you.
I should have welcomed you early. I'm so sorry. State Representative Mary Lightbody is here with us today. Thank you.
So
Mary.
good to see you.
Yes, let me just correct the statistic, and it's a wonderful organization and a website called trevorproject.org. 57% of transgender, non-binary youth who have undergone conversion therapy report a suicide attempt. Trevorproject.org. So it's a very informational website and have some great presentations on there and so forth. So could you share, Amanda, maybe some of the programs and the different ways that you're engaging kids? What does Kaleidoscope do every day to engage youth?
So our drop-in center is open Tuesday through Friday. We have, discussion groups that are sometimes affinity groups, so specific to an identity such as trans or non-binary that is run by our trans and non-binary staff members. We have a group for queer youth of color, which is run by our staff of color. We also just have art club, movie and pizza night, things like that. We are trying to get a little bit more into the advocacy space and letting the youth, learn how to advocate for themselves both at home and in their local governments. So we have a relationship with Equality Ohio where we're working on some of that as well, teaching youth how to write and speak testimony. We've been engaged in like postcard campaigns and stuff with our representatives and things of that nature. We also have a community-based housing program, which is focused on that statistic that you mentioned earlier, where LGBTQ young people are more than 120% more likely to become homeless than the general youth population. So we have housing programs, included rapid rehousing, where we have a couple of apartments in downtown Columbus that we're able to house youth in, as well as a supportive co-housing environment that's a 3-bedroom unit. Where young people engage in house meetings, they have case management services, wraparound services, really trying to help them become independent young adults and send them on to be successful. So that's our newest program. It's been around since 2019 and really serves that 18 to 24 age range. Young people who are younger than 18 and experiencing housing insecurity or homelessness, we then refer to Huckleberry House, which is our crisis center for youth in Columbus. So those are some ways that we're engaging with that kind of issue as well.
That's wonderful. Thank you. So I wanted to leave it open for a couple of questions. You'll have to shout it out. We don't have mics out there, but if you could have a question and I'll repeat it for everyone at home to hear, and then the panelists could answer it. Are there any questions?
I actually had a specific. First of all, I'm a proud lesbian, have been married for 12 years, 2 children, our daughters, and I get corrected on pronouns every day because I don't do well with them. So she educates me. But I primarily work in senior care, and so I hear a lot about Kaleidoscope and your mission, and Dr. Atkins, what you're doing in your practice. And for about 25 years, I've worked in senior and elderly care, and the stigma is still so much there, and I feel like there's so many holes where our senior population are falling through the cracks and not seeking out treatments that they should have access to, or have benefits, or hospice, or home care, or assisted living, or all of these things, for fear of not that we've come a long way, but for fear of how long they've lived in secrecy and silence, and being able to come out as an older adult and live openly and seek these services. Do you see senior population seeking out care from you?
Yeah.
Is it primarily adolescent? I guess it's kind of a very broad question, but just curious.
I mean, there's certainly some.
Can I repeat it real quick just so I hear it at home? So the question is about stigma in senior and elderly care, seniors falling through the cracks, such as hospice, home care, assisted living facilities, and so forth, for fear and stigma and so forth. So if you could answer that.
Yeah. I mean, I definitely see some patients at our office But I definitely agree with you and see the holes in general, because a lot of programming doesn't have the specific focus for older adults. And I think it's definitely an area that gets neglected. Because, and the reasons that you mentioned, like if someone's just lived longer with the stigma, there's still going to be lots of issues that are going on, and the isolation could be very intense. I'm not sure of any local LGBT organizations for seniors. There might be, I'm not entirely sure.
I don't think so.
Yeah,
There's a national program called SAGE, that I know there's a SAGE in Cleveland that's attached to the LGBT Community Center of Cleveland. But I don't think we have a chapter here in Columbus.
I think it's a great point. Like this is everyone that deals with this, and every person at different stages will have unique things and needs. So it's something that is definitely a need there and could use a lot more support.
Somebody needs to start another nonprofit focused on seniors in your copious free time. Anyone else have questions? Okay. Well, I just want to wrap up before we kind of run through some local information and just ask each, question, yes?
Yeah.
The question is about monkeypox.
It's not that serious a disease, I guess, and yet they seem to be advertising that like gay people do the gay, and I just should be careful about it.
Yeah.
So, you know, where's that falling to?
I feel like I have a lot of feelings and thoughts about how it's being covered. Because there's the issues around it being misnamed as a sexually transmitted infection also, which is not really technically true. It's skin to skin contact, like close contact could be sexual skin to skin contact potentially, but it's not necessarily for sure. And there's lots of stigma, as we talked about earlier, with sexual stuff in general. So STIs certainly have lots of stigma. So then it being labeled as such, and then talking about it being in the MSM, or men who have sex with men population, certainly it doesn't help. It is not nearly as like serious as some other infections and things that we're talking about, sure, but it certainly has complications, and it is real, and it's something that we do need to be using prevention tools for. But I have been frustrated a bit with some of the coverage and reporting of it that just feels a little panicky, as opposed to us just talking about actually educating everyone for how it is truly transmitted and what people can do to protect themselves. So I think the coverage is just more focused on the panic and our late response, which is true. Like, and there's not a large vaccine pool at all. So there's people who could be at risk are certainly not able to get the vaccines. Even, I mean, Columbus Public Health is going through them as soon as they get them. So we're just not getting large numbers. So it is something real that we need to be discussing. But I think educating ourselves, I think my answer to that is educating ourselves on truly how it's transmitted and how we can protect ourselves is, I think, the moral, like, that's what we need to be focusing on more than
You
anything.
guys are so young, it reminded me, the first time I heard it on the news, it was very much where they started talking about.
HIV.
Yeah,
Yes, HIV.
absolutely.
Yeah, there's been lots of correlations with that too. And it's just, too many of the headlines feel similar, and the way that we just keep repeating about it being in the gay population, it's not helping, because then it's having people who like maybe aren't at risk with their current practices or contacts, they're freaking out because they think, I mean, I especially have some older folks who were around for the beginning of HIV that are just panicking, but I was like, do you really have contact? Like, because some people do, but like some of it's not, we need to educate ourselves. Yeah. You're right, there's a lot of similarities with how it's being portrayed. We just need to educate ourselves about transmission and ways that we can prevent it.
Other questions?
In line with that, because I think it is promoted as the next HIV from the AIDS. Oh my gosh, here we go with that again. Do you have any suggestions on the best way to combat bad information or rumors, disinformation, even with the LGBTQ surplus population or fear of being in the second bathroom and so forth.
Yeah.
Training, those kinds of
And the question was just about combating misinformation or bad information related to LGBTQ.
Was that specifically with like the monkeypox question?
No,
So-
right.
Or just like,
No,
or just in
it's
general?
totally general. Just in general, but that's bad information too.
Yeah, right. Do you have initial thoughts?
My first thought is always like, be the role model that you want other people to be. And kind of like start with, you know, the good information, start with the good communication on where you stand on these issues, and let everybody else, you know, fall in line behind you. I think sometimes folks are sharing misinformation or have a negative view on some population, because they're hearing it from other places and they're hearing silence from other folks who might disagree with them. So I think, again, you know, it's the same kind of thought process as we talked about earlier with like really being visible about that allyship, making sure that people know, that your children know that you're there to support them. Make sure that all of your friends know where you stand on these issues, and that, you know, there are certain things that are not okay with you. And the more we can get that kind of information out there, maybe we'll get something across. I think when we hear the negativity, it's coming from a very loud vocal minority, and I think the majority needs to be louder.
I think just with the same previous question, as far as educating ourselves, I think the more we look into the issues on our own and can respond, like what you were talking about, I think it could be really impactful. And also when you're engaging with folks who you already know they're saying things that are not true and it's misinformation, or you're not sure but you're a little skeptical. I mean, it's really challenging, myself included, to not just be reactionary to that and want to write the person off and say all kinds of expletives in my head and all kinds of stuff. But I think sometimes pushing people to like, where did you get that information?
Yeah.
Sometimes just asking can be helpful, because then they're like, oh, shit, I actually don't even know. Or it was someone posted it on Facebook, not even a news article. And like, that's how a lot of the misinformation spreads, is that it's a lot of word of mouth stuff, and it's not actually based in anything. You mentioned something about like transgender folks in like bathrooms. Like there's so many times people have said or heard something about that not being safe for other folks. Like, you know, a trans woman going into the women's bathroom, that like somehow this person's a predator. That person just wants to use the bathroom. Like, there is no actual stories of someone being a predator. Like, where did you get that story? Where did you get this fear that that's somehow not safe, or that shouldn't be allowed, or that's any number of negative things? Like, where did you get that information? Because a lot of times people don't have good answers. So asking them where they get it and trying to come from a calm, inquisitive, curious place instead of just reactionary.
I think a lot of it's fear too.
Lots of fear.
Fear of other or different or don't understand.
Right.
So you just kind of land there and
Yes.
stick with that.
Yep.
Any other questions? Mary?
This question, I'm almost self-censoring myself, so I'm going to ask it, but I figured out that you actually might get the answer, or one of the answers. So, am I correct that there is a biological foundation into an individual's identity, and that not all babies are born XX or XY, and that there are babies who are born with external genitalia that might be the other, because the differentiation kind of didn't take place after we were involved in our development. I wonder if you could speak to that, because I've just always been very curious.
Yeah.
And then doctors, I know, in the family sometimes make the decision at the birth of a child.
Yes.
Oh, you're a girl, oh, you're a boy, which may not be better for the child is the result of you.
Yeah.
I wonder if you could just speak to that.
Yeah.
That's a great question. Yeah, and the question just is about the medical biology, essentially the foundation of the chromosomes XX versus XY, and is a child born one way or another?
So I think there are two issues here. So there is like organs and then someone's gender identity. So there is definitely folks that are intersex is the term that is used. That is not a cut, clean and clear XX equals this set of what we call female body organs and XY equals this set of what we call male body organs. So there are folks that for various numbers of conditions might have some variation with that. So that is a real biological reality for sure. And it's something that doesn't get enough attention and again, is not covered in a lot of our education. You mentioned something about what a lot of times at birth, some adult, not this baby, makes a decision for this person and essentially like mutilates the body, like, you know, does corrective procedures, they think, for this baby to make it kind of conform to the rigid binaries that we have. So yes, there's certainly biological places that are not just XX, XY, and this equals those body parts. So that is a real thing. Gender identity, though, is a separate thing altogether. And a lot of times when we're talking about, like when we're doing lectures and talking about things like folks that have reproductive organs, we always are talking about like women's health. That's what we call it. But it's like you could not identify as a woman and have a uterus. So I think decoupling what the body parts and like the chromosomes say from gender identity is the really important part here, because the uterus doesn't have a feeling about whether or not they identify as female, male, non-binary. You know, that doesn't matter. And really, we as doctors should also not care. We should care that it's a uterus and we know what to do for certain things. You know, we don't need to assign genders to that. So body parts don't have gender. The person's mind, soul, whatever we're gonna, you know, call it, that is where the gender identity comes from. As far as biological basis in that, I don't have strong evidence or things to cite for that. There's certainly a lot of theories, and there are some studies out there that there have been functional MRI scans done and various testings that folks who identify as like trans feminine have more similarities with folks who are XX chromosome cisgendered folks. So there could be some of that, but as far as like it being a biological determination that says who the person's gender identity is, I don't think we can really say that. But I think the safest thing is for us just to be decoupling body parts with genders. Does that answer the question? Okay.
If I could add really quickly too, if you are interested in more self-education about intersex identities, which is a great like research rabbit hole to fall down later. There's a national nonprofit organization called Interact that works in that space, and you can find them at intersexadvocates.org. And that would be a great place to do more reading on that issue later if you are interested.
Last question. Going once. Yes.
So mine isn't a question, but a comment and call for action, like we talked about politically. Kaleidoscope is pride of Albany and non-profits. And so we're a generous community in New Orleans. And that's the step we can take is to support those organizations with our gifts as well. So they can raise the awareness of the community, be safe places, and educate our students and people. So
Absolutely.
I just wanted to put that call to action.
No, I will share that definitely, the call to action to support the nonprofits that are doing this wonderful work like Kaleidoscope and Pride New Albany and Wellbeing Connection and all of these organizations doing the work, to support them with our dollars so that they know that we value them. Absolutely. Your website is
kycohio.org.
kycohio.org. Yes, and you'll receive a packet of information. You have some things with you there, but you also receive a digital packet with information and links to all of these wonderful resources for you. And we do call to action. That's always how we end, because we don't want to just talk about this, right, and go back to our lives. We want to be impactful individuals in the community, really leading this change. So that's always my last and parting question is, what is the single most important thing that we as community leaders can be doing?
You say single most, that puts such pressure on the answer.
You can say two. Or 7.
Believe youth when they tell you who they are, period. Ask the youth what you can be doing to support them. And keep yourselves educated and let your community know where you stand on these issues and educate them as well.
When we're thinking about it from a community perspective, I really think events like this that are connected to calls to action, I think is the biggest thing. Sometimes there is this idea that we talk about these things too much, and it's like, oh, another pride-related talk or session. It's like, have we had enough of this? It's not June anymore. Can't you move on to something else? You know, so I think just continuing to do these things and recognizing that this is still a big need. And even if it's not directly affecting you, like, you know, people that it is. And this is something that's still talked about for a reason. It's not because like things are still, there's room for improvement. So I think just continuing to do these community events with calls to action, like not just talking about it, but actually doing real tangible things to show up for the community. I think, yeah, just keep doing that.
Thank you. Thank you. Yeah, that was something that Pride New Albany said too, and that was one of her parting comments. Is just it's hard, right? If you're a family member going through this, or if you're a child struggling through this, it's difficult. It's not easy. Many people wouldn't choose the road if they could. So recognize that. And it's important to connect these resources, right? We don't want to just talk about it. We want to find the connection points and link the support networks together. So you'll find a bunch of resources there. You'll see the Wellbeing Connection has a great card that has about 10 different websites, all on different advocacy and information. You have that in there, as well as, well, I'll tell you a few. I don't think you have all of these in there. The trevorproject.org is another great local resource. Wellbeing Connection, and the Wellbeing Connection also has a wellbeing teen group. They were supposed to be here today. Sadly, they couldn't be, but it's a wonderful organization that's really dedicated to the mental health space. They have programs, events, and resources on their website. It's thewellbeingconnection.org. You have some literature there about them. And again, they do have the Teen Connection as well. Stonewall Columbus is, it is on here. That's good. Okay, so they're on this card as well. That's just another one that we received information on that's very important in helping to connect the community. Of course, Pride New Albany. You will also see in here, not related to LGBT, but there's a Science and Impact of Addiction community support event that we'll be hosting here. So you have that information, as well as the Healthy New Albany just released the fall and winter program. So that just opened up, actually, I think today. So be sure to check that out. We will definitely keep having these conversations, and thank you so much for all the time. Yes, that's my next, sorry. Up and coming Lunch and Learns, there is also a flyer in there. Our September Lunch and Learn is episodic food insecurity, understanding how inflation, rising food costs, and the housing crisis are impacting families. October 21st is an awesome event, practical tools for families to support mental well-being. It's a resiliency toolbox event with Akia Red and some other great panelists. And then in November, we'll be talking about the challenges of caregiving, supporting aging, family dementia, Alzheimer's. So don't miss those. And thank you so much. Go out there and keep doing the good work. Oh, and a survey. Sorry. Thank you. Please fill out the survey. Anything else? Thank you both so much. Thanks all.